Bismillah Rahman Rahim. Today we will discuss about the hyperuricemic arthritis, which is gout. In gouty arthritis, there is hyperuricemia, deposition of monosodium urate crystals within the joints or around the joints. And it is characterized by transient attacks of acute arthritis. Gout is divided into two main types. One is primary gout, in which there are 90% of the cases. There are enzyme defects, they are unknown, and metabolic defect is overproduction of uric acid with normal excretion or with increased excretion of uric acid. And then is with known enzyme defects, for example, partial hypoxanthine, guanine, phosphoribosyl transferase enzyme deficiency. And there is overproduction of uric acid. Then 10% of cases, they are secondary gout. And secondary gout is associated with increased nucleic acid turnover. For example, patients of leukemias, which are treated with chemotherapy, there is increased nucleic acid turnover. And with this increased nucleic acid turnover, there is overproduction of uric acid with increased urinary excretion. And chronic renal failure is also a cause of secondary gout. There is reduced excretion of uric acid with normal production. And inborn errors of metabolism, for example, complete HGPRT enzyme deficiency, which is associated with Leach-Lehmann syndrome. In this syndrome, there is overproduction of uric acid with increased urinary excretion. So then is purine metabolism. There are two pathways of uric acid synthesis. One is a de novo pathway and other is salvage pathway. So there are ribose 5-phosphate enzyme, PRP synthetase, and then nucleic acids are formed which are acted upon by HGPRT enzyme, and then hypoxanthine and ultimately xanthine and uric acid. So this is the purine metabolism. So pathogenesis of gout. So hyperuricemia can result either from overproduction or reduced excretion of the uric acid. And there is disturbed renal transport system. Along with this, age of the patient, duration of hyperuricemia, also there is genetic predisposition, alcohol consumption, obesity, and certain drugs. They are also related to the pathogenesis of gout. There is precipitation of monosodium urate crystals in the joints. So if there is long-standing hyperuricemia, then precipitation of urate crystals in the joints. And these crystals, they are phagocytosed by macrophages, and neutrophils. Complement activation takes place, and neutrophils, they are recruited to the site of crystals deposition. And then the neutrophils, they are lysed, and they release the crystals and also release of lysosomal enzymes which act on the site and produce tissue injury. There is a release of leukotriene B4, prostaglandins, and free radicals. Similarly, the phagocytes, that is macrophages, they also ingest the monosodium urate crystals. And there is a release of interleukin 1, tumor necrosis factor, interleukin 6, and interleukin 8. And these mediators, they act on the synovium and then cartilage of the joints. So they lead to release of proteases and then tissue injury at the site of gouty arthritis. So morphology of gout. There are 4 morphologic features which will be discussed. That is, one is acute arthritis, and there is chronic tophaceous arthritis. Then there may be tophi formation in various sites, and then nephropathy, gouty nephropathy. So acute arthritis is characterized by dense neutrophilic infiltrate that infiltrates the synovium and synovial fluid. And monosodium urate crystals, they are arranged in small clusters in the synovium. These crystals, they produce edema in the synovium, and there is congestion. And there are also scattered lymphocytes and few plasma cells. And these acute attacks, they are often transient, that they remits. Then is chronic tophaceous arthritis. It results from repetitive precipitation of urate crystals. And urate crystals, they encrust the articular surface and forms visible deposits in the synovium. Synovium becomes hyperplastic and thickened fibrotic by inflammatory cells and forms a pannus that destroys the underlying cartilage. And there is bone erosions. So that is chronic tophaceous arthritis. Then formation of tophi in various sites. So tophus is a large aggregate of urate crystals which are surrounded by intense inflammatory cells and foreign body type of giant cells. Tophi can be formed in the articular cartilage, ligaments, tendons, and bursa. Sometimes they may also occur in soft tissues, ear, toes, and fingertips. So that is tophus formation in various sites. Then is gouty nephropathy. So gouty nephropathy results in stone formation in the kidney, and there is renal, medullary, interstitium attributes. They contain tophi. Uric acid nephrolithiasis and pyelonephritis can occur in chronic gouty nephropathy. So this is excision of the great toe affected by gout, and this is a tophus. These are the monosodium urate crystals, and then these are the various types of cells, that is multinucleated giant cells, then fibroblasts and macrophages, gouty tophus. So gouty tophus, they are often in the big toe. So clinical features of gout: patients may be asymptomatic. There may be hyperuricemia when uric acid is measured in the serum. They may present with acute gouty arthritis, sometimes intercritical period, asymptomatic intercritical period, and then chronic tophaceous gout. So asymptomatic hyperuricemia occurs in around the puberty and after menopause in females. Acute arthritis is characterized by sudden onset of pain in the big toe joint with localized swelling and hyperemia, local signs of inflammation. Then general symptoms may be seen like mild fever. And these attacks are often monoarticular. And 50% occur in the first metatarsophalangeal joint. Then is asymptomatic intercritical period. So acute attacks, they resolve and they lead to a symptom-free interval. But in the absence of appropriate therapy, the attacks recur at shorter intervals. Then is chronic tophaceous gout. Develops on average about 12 to 20 years after the initial attack. And appearance of chronic tophaceous arthritis often occurs after a long period of hyperuricemia. At this stage, radiographs show characteristic extra-articular bone erosion caused by osteoclastic resorption of the bones. And renal manifestations may occur in the form of renal colic, then passage of small stones in the urine. In 20% of patients with chronic gout, they die of renal failure. So that is about gout. Then few words about pseudo-gout. So pseudo-gout is the deposition of calcium pyrophosphate crystal deposition. It is also called chondrocalcinosis, and the cause is often unknown. So that is about the gout and pseudo-gout.